Hey guys, welcome back and you are watching your medical channel MMS, Makes Medicine Simple. Yes guys, medicine is fun if we make it simple. So in the previous lecture we have discussed about the introduction of rheumatoid arthritis from the rheumatology playlist, and today we will talk about the epidemiology, etiology and environmental factors that affect rheumatoid arthritis, the inflammatory arthritis. We have one rheumatoid factor which is an antibody against the antibody and IgM against the Fc portion of IgG. Also in rheumatoid arthritis, you will have elevated levels of ESR and CRP, the inflammatory markers, and also hepcidin, the acute phase reactant, right? So here is the beautiful picture of one rheumatoid arthritis patient, and her name is Simran and she is my imaginary patient. Okay, so with this picture you can imagine now that rheumatoid arthritis not only affects your joints like your PIP, your MCP and your wrist, your knee, but patient also manifests with the extra-articular manifestations. Like patient might have pericarditis, pulmonary fibrosis, scleritis and episcleritis, CNS manifestations, vasculitis, subcutaneous nodules and Becker cyst, along with the constitutional symptoms like fatigue, weakness, weight loss, and cardinal signs of inflammation such as redness, swelling, pain, hotness, and loss of function. So in this lecture, we will talk about the epidemiology, genetic considerations, that how the genetic makeup of one individual put him at risk to develop rheumatoid arthritis, and environmental factors like cigarette smoking and some viruses that increase the chances of having rheumatoid arthritis. So before we talk about the epidemiology and etiology, let's recap something important, that rheumatoid arthritis is an autoimmune, chronic, systemic inflammatory disease which affects small joints but symmetrically, and it's common in females. The female to male ratio is 3:1. Also, patients with rheumatoid arthritis might have both articular and extra-articular features because this is systemic inflammatory autoimmune disease, right? Also, as we already discussed, that rheumatoid arthritis is one symmetric autoimmune inflammatory arthritis. Means patient will come to you with the cardinal signs of inflammation like redness, swelling, pain, hotness and disability, loss of functions, which worse in the morning and improve as day passes with the physical activity. Also, your patient will have elevated levels of ESR and CRP because this is the inflammatory arthritis. When it comes to osteoarthritis, it's asymmetric, non-inflammatory, means no cardinal signs of inflammation, no elevation in ESR and CRP and hepcidin, and unlike rheumatoid arthritis, in osteoarthritis, the stiffness and pain worse in the evening on place of morning. Let's talk about the epidemiology. So rheumatoid arthritis affects 0.5 to 1% of the adult population worldwide. It's more common in females than males. The female to male ratio is 3:1. The typical age of presentation is between 40 to 50 years of age, though the incidence of rheumatoid arthritis increases between 25 to 55 years of age, that plateau until 75 years and then start to decrease. The high female preponderance is attributed to estrogen in females, as estrogen enhances the immune response by stimulating the production of tumor necrosis factor alpha, TNF-α, a major cytokine in the pathogenesis of rheumatoid arthritis. Let's talk about the etiology and genetic considerations. The etiology of rheumatoid arthritis is unknown, idiopathic, because we doctors are idiots. Sometimes we cannot find out the pathology and then we name it idiopathic, right? Also, some genetic makeup plays an important role in the development of disease. Like one individual with the first degree relative with rheumatoid arthritis is at 2 to 10 times at higher risk to develop rheumatoid arthritis. Also, HLA-DRB1 allele that shows the higher risk of disease, right? An individual with the HLA-DQ and HLA-DR and seropositive disease, seropositive means positive for anti-CCP and rheumatoid factor, have more aggressive disease as compared to the other population. In the Western European countries, allele 0101SE put them on high risk to develop rheumatoid arthritis. Also, allele 0401 and 0404, which is approximately in 50 to 70% of northern European countries, put them on risk to develop RA. In Asians like Japanese, Koreans and Chinese, allele 0405 and 0901 put them on risk to develop rheumatoid arthritis. And lastly, PAD14 polymorphism, which is associated with rheumatoid arthritis only in Asians. PAD14 polymorphism means it's a functional halotype. Halotype means a set of DNA variations or polymorphism that tend to inherit together. So it's a functional halotype of the peptidyl arginine deaminase 4 gene and the increased activity of PAD14 gene associated with the abnormal citronylation of the fibrin strands, and that put the patient to develop rheumatoid arthritis. Lastly, let's talk about the environmental factors like cigarette smoking. So cigarette smoking put an individual 1.5 to 3.5 times at greater risk to develop rheumatoid arthritis. Also, women smokers are 2.5 times at greater risk to develop rheumatoid arthritis. Risk from smoking also associated with seropositive patients who are positive for anti-CCP and rheumatoid factor. Certain viruses like Epstein-Barr virus also increase the risk to develop disease. Patient with Epstein-Barr virus has high titer of IgG, immunoglobulin G. So thank you so much for watching, and please do subscribe your medical channel MMS Makes Medicine Simple and help this beautiful lady with rheumatic disease. Her name is Simran and she is my imaginary patient. So help her to reach and teach more and more people like her about this nasty disease. Stay safe, study a lot. Thank you so much guys.